Good afternoon. My name's Jess Perillo. I am the ABIM Foundation's Executive Vice President. Thank you for joining us for our second Trust Conversation of 2025, our core webinar series and element of our Foundation's Building Trust initiative. Before we begin, I'm going to review a few logistics. The meeting will be recorded and shared. And when the presenters are speaking, we will have the lines muted just to reduce any unnecessary background noise, but there will be a chance towards the end of the conversation for the speakers to answer any questions you might have. So we'll encourage you to enter those questions into the chat throughout the conversation, and we'll be paying attention. This webinar is a bit different than our usual. We'll end the conversation portion of the webinar after about 40 minutes, at which point we're going to ask all of our Foundation Health Equity grantees to remain on the line, and folks that aren't participating in our grantee cohort to exit the meeting. So it'll be a little bit shorter for the bulk of you on the line today. But we're joined by Jody Platt. She's an associate professor of learning health sciences at the University of Michigan, and Lauren Taylor, assistant professor in the Department of Population Health at NYU Grossman School of Medicine. Both previously served as Academy Health and ABIM Foundation scholars in residence, where they provided guidance to the initiative's research community, which explored trust at an organizational level. And together, Lauren and Jody authored Assessing Trust in Healthcare, a compendium of trust measures, which offers a framework for addressing the issue of clarity in trust research and measurement. Jody and Lauren, thank you for joining us for this timely conversation.
Thanks, Jess. It's good to be here.
Well, I'll start just asking you to define trust in the context of healthcare. It's broad, it's complex, and tell us a little bit about the compendium.
Okay, so defining trust is, I may punt a little bit on that because that's sort of, I think, what we're going to be talking about for the next 40 minutes. But another sort of a off-the-cuff definition, it's sort of the willingness to be vulnerable to somebody or something else for a given set of tasks or for some purpose, right? It's for there's parameters around it, right? And we'll talk about some of those. It's certainly sort of broad and complex, like you said. And I think what we were trying to do with the compendium is to help people break down that definition and what does it mean to operationalize that definition. So who's involved in trusting, who trusts, who's being trusted, or what is being trusted. What are the conditions around that? And what do you really mean by it? We sort of didn't want to make any assumptions about what people already knew about trust going into it, or measurement, or any of the other sort of. Anybody that's interested in doing research hopefully can benefit from the compendium, but mostly people that are sort of working in health services research, healthcare, or even sort of in the operational space and trying to understand what it means for the people that are working in health systems to trust each other and the organization and their patients.
Yeah, a great and necessary starting place for a lot of folks, I imagine. So why is it important? Why are we measuring this? Why does it matter to health outcomes, to equity, to some of the challenges we're up against today? Morning, can I ask you your thoughts?
I can try. I just saw my internet go wobbly, so I'm a little nervous. But so trust is a requirement for most successful delivery of medical care. If I don't trust the system, if I don't trust a healthcare delivery organization, if I don't trust a provider, I'm unlikely to show up in the first place. I'm unlikely to give a full account of the relevant information. I'm unlikely to follow up or sort of follow the recommendations of a clinical team. And so it becomes very difficult for the healthcare delivery system, to say nothing of public health agencies or other healthcare players, to do their jobs where they can't assume some basic level of trust. Now, how much trust is required? People debate, like, do I need to absolutely fully trust? Maybe in some settings and maybe less in others. You know, you can think about two cases that are very different. One is, I've recently had a biopsy. I have a newly diagnosed cancer. There are a lot of potential treatment avenues, and I'm sitting with an oncologist in their office. That's a case where I think you need pretty high trust because there's potentially a lot of judgment involved in that oncologist choices about steering me to this clinical trial or that clinical trial or making trade-offs that I think are in my best interest. So trust, really, really important. Another example, sort of hyperbolic on the other end of the scale, I get wheeled in after like a traumatic car accident and some surgeon is going to operate on me and I'm sort of semi-lucid. Is that a really high trust situation? Maybe not. Maybe we say that that's characterized by something else because I'm not even really making a choice. I'm basically just going with the default option. So this is part of what makes trust complicated is that like even within healthcare, we can point to different just patient-provider interactions where we might think trust is meaning something different, much more salient than others. But overall, I do think COVID was like another episode of reminding us that if we can't assume some basic level of trust, many of the processes that we need to secure not only individual health outcomes, but population health outcomes become tremendously difficult.
Yeah, and you made a point in your compendium to differentiate between trust and trustworthiness, being worthy of the trust we're seeking. Can you say a little bit about that?
Sure. I feel like this has become my hobby horse, Jody, so I'll take this one. So I do think trust and trustworthiness are different, and it's important to distinguish them. Trust is, as Jody said, the willingness to be vulnerable, and I see Jason picking up on this in the chat, at the risk of some exploitation. So that's an individual level attitude, belief, maybe perception. Trustworthiness is the characteristic of being deserving of trust. And as a result, it's a really normative concept. Jess and I could look at the same person and I could say that person's really trustworthy. And she could disagree and say, oh, I don't think that person is trustworthy. And we would sort of have to suss out, well, what makes them trustworthy on your account and what makes them trustworthy on mine. But it's important to separate these two concepts because then we.
Uh-oh.
We lost you right at her point. Hopefully Lauren will come back with us in a moment.
Want to address. One is
We lost you at because, Lauren.
and the other is I don't trust a trustworthy actor. And those are different.
Can you just repeat that last sentence again for us? Your internet seems to be going in and out for us.
Let Jody take it then. She knows this stuff.
I do, but you can anyway. So it's I don't know that it's important to suss it out because it's because it is the well because of what sort of Lauren was talking about in terms of like it's trust is very much an active relational kind of process, and trustworthiness in some ways is an outcome, and and yet it can never truly be sort of knowable. And she's going to sort of put the rest of the answer in the chat, where trustworthiness is eventually something that we're going to have to accept as true. So
yeah, I found it helpful because of where it puts the burden.
Yes, that's right.
And rather than trying to get people to trust you, you're focusing on that I created the conditions for that trust to exist.
That's great. That's great.
Yeah.
And the best you can do is hope that you've accomplished that in many ways.
Yeah. Mm-hmm. So you touch on this in the compendium, but trust measures vary across stakeholders and patients and clinicians and institutions and policymakers. So how how do I just like start to think about this if I'm a health system or a clinician looking to start this work?
Yeah, I mean, I think the starting point is sort of being clear about what your question is and who you're like, what the relationship is that you matter and what's the context. So Lauren gave a bunch of examples, in sort of defining trust that are important, right? Is the context where patients are at a very sort of a high sort of vulnerability moment where the need to trust is quite high. The trustworthiness of clinicians is very high. Is the need for trustworthiness is very high. And is that the context you're looking at? Are you trying to understand the trustworthiness of your organization? Do you care about clinicians in that moment? Which types, are you caring about nurses or physicians or all of them? There are some of the measures that are in the compendium that talk about trust of communities towards organizations. So like the mistrust index in particular was sort of created with the under the observation that not everybody is going to have a provider or even have that access to care or want to access to care, and yet will have very strong beliefs about whether the health system is trustworthy or not trustworthy, and what's their trust in that organization. So I think the first step is really the clarity around what are the relationships you're trying to examine, and then what do you mean by trust? And if you had to sort of substitute sort of trust in that case, like what other words might you use? Is it reliability? Is it competency? So again, in the context of surgery, like the competency of the clinician may be way more important than their relational capacity. And so making sure that you're evaluating both of those attributes, if that's what you care about.
You see a question from Mark in the chat, which I just want to weave in here because there's also these global surveys that measure trust, like the Edelman Trust Barometer, that are looking at insights into public perceptions of these sort of things like credibility and ethics and competence across multiple sectors. I don't think you talked about it at all in your compendium, but
we didn't talk about that one, but there are, so like the Bob Linden sort of did this really, he tends to like take these Gallup like national polls and put them together and sort of and then the nice thing about them is that you can evaluate that kind of global trust over time, and you can see it increasing or decreasing. A lot of times when you hear trust in the medical profession is declining or trust in medicine is declining, it's based on those types of surveys that are asking quite globally. And that can be helpful to understand, I think, as a profession and as a member of a profession, to have a sense of what the public thinks about your vocation. But if you're an organization, it can be hard to know what to do with that information. How is that actionable? So there's a role for it, but it's, Lauren, if you have other things to add about that.
I think one of the other interesting trends that Edelman has picked up on is this idea about the closer to the bedside someone is, the more trusted they are, and the more abstract the idea is, the less trusted, which is interesting because so nurses are always the most trusted professionals, and then you go through a list of like physical people, doctors, pharmacists, etc., and then you get to something like insurance companies or the system always really struggle. So it means you're probably starting from a different baseline if you're a health insurance company trying to earn trust or build trust than you are if you show up as a generic kind of healthcare provider in scrubs.
Awesome. And thank you, Catherine, for putting the link in the chat. I was just giving it a quick scan to make sure we addressed all of the questions about sort of framing the work, what we're talking about when we're talking about trust, and some of the ways to think about beginning the work to measure it. But let me know if I missed one. And Jimmy and team, I'll ask you to lift it up in a moment. But moving on, so what are some of real world examples of where trust has been measured and acted? Have you seen this done well? Have you seen it done? Maybe we'll start there.
I know that it has been tried. I haven't seen it done sort of system-wide, but, a primary care practice here or a particular kind of usually outpatient clinic there will try and unroll a measure. In many cases, people start not with a quantitative survey measure. They sort of say, well, first we'll do some interviews, or we'll try and work with available data that we already have, patient comments or something like a CAPS equivalent for an outpatient perspective, because they don't either have the resources or the time to start fielding a new survey. I would just say, Jody and I were talking about this yesterday, there's a real temptation to work with the data that you have, and yet trust is such a finicky concept that it can be difficult to kind of read a set of comments that are generically collected based on like, how was your visit today? And really put a lot of faith in like, oh, these 7 patients have high trust and these ones don't. So, Jody and I could talk about and share some of the available trust measures that are in wider use, more validated, sort of available for a little bit of plug and play. But it's a very thorny issue because on one hand, trust is very context dependent. And on the other hand, you want to use something that you have some confidence that like psychometricians and methodologists have kicked the tires on. And so I find that when people come to me and say they want to measure trust, that tends to be the rock in the hard place that they get a little stuck in.
So beyond measurement, because I think there's obviously a lot of talk about trust these days. It's on people's minds. In addition to kind of figuring out how to gauge it, what are the biggest barriers to getting organizations and health systems to implement the tools, and what else are you seeing?
I mean, I think the biggest barrier is that it's hard, even when the right. I mean, and yet, I do think it's important, and I think that some of the things that I've done is to try to figure out what are the behavioral implications. So we talked a little bit about like if there is low trust, patients won't be as forthcoming. They may not follow answers. So there's ways in which you can couple through your investigations about trust with the actions and attitudes and beliefs and quality of relationships, the outcomes that you're interested in getting. So so making it kind of a both and scenario in your work around trust. And then I also think we talked about yesterday sort of that the act of measuring can be a sort of an act of trust building in and of itself. So if you care about it enough to say, we're going to create this environment where we're going to talk frankly about it, then that's important. Again, with the big asterisk that like you also don't want to get stuck in the moment of like trying to manufacture trust and creating surveys that make you just look good as an organization.
Yeah, and I think my experience with burnout work is that it can actually do harm too if it's not paired with some either feedback loops to say, you said this, we heard you, we care about what you've told us, or actually doing something about it. And I think there can be a real drop there. But I get too that it's a signal, at least, that there's an intentionality there. I want to pick up on a loop and skip ahead a little bit because it's kind of being talked about in the chat here. But this was a question I was thinking, Jody, given your work on AI, is sort of how do we measure trust in an AI-driven environment? Are there any existing metrics or frameworks that patients or clinicians could be looking to, and how can we use these insights to improve care delivery? The question in the chat was about telehealth in particular, but I imagine there's a overlap there.
Yeah. So the answer is no. We do not have good measures of this at all. And in fact, what we do have. So if you do, I mean, you always sort of start with a literature search as a nice, good researcher, but look at things that you already do in terms of assessing the quality of that literature. Where does it come from? What are the psychometric properties of the questions, things like that, to sort of understand the limitations of what it is that you're finding, but certainly using it as a point of departure seems okay with me. I think the other piece is also trying to understand, what are you trying to evaluate when you're talking about trust in the technology? So again, does it work or does it not work? And for a lot of people, especially from the technology space, that's sort of what they're thinking about when they talk about trust, is like, does it make mistakes or not? And for some people, that's what trust is about. I think for the healthcare space, there's a lot of space for understanding what is the impact on the relationships in healthcare, which is, again, one of the big claims of AI and telehealth and all these things, that we can make those relationships better while also creating the sort of efficiencies that we're all sort of constantly after. So, so we need more. And there's a tremendous opportunity here.
Thank you. And I can't recall if you talked about GME in the compendium, but you have a question in the chat from Janice about the clinical learning environment. Any thoughts from either of you on how this would apply or relate?
It came up a fair bit in our review, if you remember, Jody. I mean, this is a huge literature just to orient people. I think we reviewed more than 500 articles.
Yeah.
And, and there's all these sub-literatures, and I would say the topic Janice is raising is one of these sub-literatures, trust in an academic medical center between teachers and learners. So there is some work there, a lot of it qualitative. One of the most interesting papers, though, I remember, Jody, is about learners' trust in themselves. Mm-hmm. And this is a really interesting concept conceptually to sort of potentially trouble our standard understandings of trust, because usually it's so relational. I trust Jody or I don't trust Jody. And this was a paper that was talking about how we think about trust in ourselves as really trust and not just something like confidence, which would be a frequently closely related term. And there's a lot of debate for those of you who want to go like really down the rabbit hole between confidence, reliance, and trust. They all have slightly different meanings, but I would say there's a bunch out there. None of it is like strongly counter to our prior intuitions about how trust works anyhow. And maybe the one other defining feature of the literature on trust in an academic medical center environment is really strong emphasis on trust as something you give to someone when you think they are capable or competent. So it's about like, can the resident do the sutures effectively? If so, then I trust them. If not, then I don't trust them. Which importantly is sort of different from how a lot of patients think about trust in choosing a provider. They often assume all providers have some requisite level of capability, and they're choosing based on, do I kind of get good vibes from like Jessica or Jody? And what good vibe stands in for is like, do I think they have my best interest in heart? Do I think they have integrity? Do I think they're going to act in a benevolent way? And so I would just call out that when we say trust is complicated, people use the word trust to mean a bunch of different things. That teacher assessing trust in a resident and me as a patient assessing trust in a physician can have really different valences.
Yeah, and it gets to the interplay between trust and professionalism, medical professionalism. And before this conversation, I would not have thought that there was a difference between trust in my competence and confidence.
Yeah.
Like I could not even, that kind of broke my brain a little bit just now. So, okay, stepping back, if we were going to get trust measurement right in the next 5 to 10 years, what would need to happen? What would success look like?
Jody.
So, I mean, I think there's a sort of a constant sort of debate among academics. It's sort of like, can we have one measure and sort of let that go, make that be the one thing out there? I think, you've probably picked up on, I think Lauren and I are both skeptical of that perspective, although there are other people that would, I think, disagree with us, that maybe for some people that would be the ideal. I think that for me, I think having, sort of more thoughtfulness in terms of what people are measuring when they say they're measuring trust would be a sort of a gold standard. Being able to sort of describe your work in the context of what other people have done is really important. I think there's a pressure to always have your own measure, but if you can have different measures in conversation with one another, the sort of the literature will be sort of the richer for it. I think that when I review papers around trust, like it's sort of like I sort of push authors to say, okay, I'm happy that you measured this, but break it down for us and tell me more about what you mean when you say you've measured trust. So if that's sort of all standard practice, then that would be, I think, a great place for us to be in 5 years. Because I think that would sort of push us to a higher level of sophistication around a complicated topic, which is really, I think, where we want to go.
Yeah. Any other thoughts about that? I think you've also been monitoring the chat.
Yeah, I think I'm good in the chat for this one.
I think probably also the conditions being in place for trust to exist in the first place would probably run all our efforts here. What's one takeaway you'd want researchers, clinicians, or policies to walk away from this discussion with?
One thing is always definitions matter. So this is similar to Jody's point, but you could have dramatically different measurement strategies that I would full-throatedly endorse based on what it is about trust or in what context you're trying to measure trust. So, you could be trying to measure trust of providers in patients, and you could say, Lauren, I'm going to ask it this way, and I'm going to ask it this many times a year, and I'm going to put it on a 5-point scale. And if you came to me for advice, I would charge you a lot of money, and then I would probably say, yes, that sounds great. Or you could be trying to measure community trust in a local health system, and you could tell me you were going to do qualitative interviews and be looking for particular keys or thematic words, and that was going to be a cross-sectional approach, blah, blah, and I could really support and endorse that. So I guess my one thing would be I really hope people walk away from this conversation not feeling like, oh, geez, I don't know the literature well enough, so I'm probably missing like the one gold standard trust measure. And if I don't use it, I'm going to be found out. The reality is I've looked for a long time. There is no single one gold standard. There are some survey measures that are used more often than others, and we can say a word about those. But much more important than being able to gesture to the one gold standard is making sure that whatever you pursue by way of measurement or assessment fits your context and the particular relationship you're trying to assess.
Yeah, I mean, so all of that, and there's, I think that some of this was in the chat and we've talked about it, but I think that the relational aspect of trust is also super important, and it also worthy of sort of thinking about, and what are the implications of that relationship and how does that impact trust? So especially in healthcare, when again, patients, because they're patients at the moment, are have a sort of higher level of vulnerability, and so like understanding what the impact is of that vulnerability on the trust relationship. Again, if you're not able to engage in a relationship, trust is not the right set of questions. When patients are well and not necessarily patients, it's also, I think that's probably your greatest opportunity for trust building, because that relationship can be a little bit more equitable. To understand sort of what the power dynamic is in addition to what the trust dynamic is going to be a helpful way of thinking about it. And I guess I'm going to say one more thing, that using both the sort of survey measures but the qualitative work together with it is what is going to make sense out of trust measurement in general.
Yeah, there's no one size fits all. And I'm glad that you said touched on equity, because I think there's been the thread in the chat, and we know earned mistrust is a problem. We also know trust in healthcare is often the lowest among marginalized communities. Can these tools help with addressing inequities in trust?
I think they can, to your point about like whether the measurement of trust can sort of foster a conversation that's helpful in trust building. If it's a way, a process of opening up that sort of, I see this, I hear you, let's work on this. But it can also go backfire if you're not prepared to follow through.
All right. I think we're at the point where we were supposed to pivot over to the audience Q&A, and I'm wondering if anything has risen up in the chat team that we have not addressed yet. It's been a really active chat, which has been exciting to see.
Hi, Jess, it's Jamie. I think there's two questions that we either didn't touch on or did very briefly. The first one was from Mark earlier in the conversation, who asked, should we take the quality of care as a given from our providers and trust them or request outcome measures before moving forward with treatment?
Do we think he's asking that in the position of a patient or as a researcher?
Do you want to come off mute and share a little more, Mark? Or you can put it in the chat if you're not. Talk.
If you can understand the Scottish accent.
Hi.
Hi, yeah, I'm phoning in from Manchester in England. I've spent the last 35 years trying to improve the information that we give patients to truly move towards shared decision making and the informed element of informed consent. And having a couple of conditions myself, I feel that my epitaph will stay, he tried, not he succeeded. And so the question is, are we really providing across the whole diversity and the educational gaps that we have sufficient support and information for patients to make truly informed choices? So a long way of saying not so much researchers, but patients. Even those of us perhaps on this call with privileged access to healthcare, I think sometimes still struggle with how do we trust our healthcare providers? How do we trust the information that we're given, et cetera, et cetera? So it's how do we turn this into practical patient decision aids and tools that truly allow consumers, citizens, patients to be informed about healthcare?
I love this question, and I won't have a fully satisfactory answer for it, but I will point out something that continually puzzles and interests me about trust in this respect. On one hand, from a public policy perspective, we always want to be providing
Uh-oh.
they would never have to trust. They could just decide directly for themselves. We would have closed the gap so much that trust and the vulnerability that's inherent in it would no longer be required. And so there's a real tension here between wanting to inform trusting decisions and obviating the need for trust altogether.
So I understood you because we've talked a lot about this, but did that make sense?
I think so.
You cut out, Lauren, so we missed
cut out in the middle there. Mark, I'm curious if it got to what you were asking. They keep putting you on the spot.
Okay.
Yeah. Thanks, Lauren.
I think also that providing patients with more information, I think does start to maybe equalize relationships. But if we had full information, we wouldn't need to trust anymore. At some point, you have to let go of the fact that you can't know everything, and that's where trust and trustworthiness becomes super important, whether you can measure it or not. Complete information sort of denies vulnerability or reduces it. Is that about right, Lauren?
Yep, that was my point. Well done.
Yeah.
And I see another question from Abby, just to get back to the clinical learning environment. Yeah, and I've heard this quite a bit. There's mounting mistrust of teachers as we learn more about bias in assessment and feedback given to learners. Anything that came up creating your research on that?
Yeah, I think it was in the same sub literature around sort of trainees and their mentors. Yeah, I mean, the more we reveal about the biases, the biases that are operationalized, that are operational at sort of all levels and in all aspects of care, the more we sort of shake that foundation of trust, right? both sides is admitting when something goes wrong, and even when systems have been sort of inequitable and unfair for a very long time, and sort of being able to own that in a way that is sort of a first step in moving forward. I think some of the work the ABIM Foundation has done, right, that sort of acknowledgement as sort of the first step of trust building.
Yeah, the work we have been doing with the Institute of Healthcare Improvement is based on the healing work for social justice, for racial justice, rather, pioneered at the Brigham and Women's Hospital. A lot of that was acknowledging and addressing harm in racism as a first step to addressing and closing the systems for change.